Good evening, everyone, and thank you for attending AACP's webinar. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. We're excited to have Rose Nierman presenting Dental Sleep Medicine Billing Made Easy. Rose has no conflicts of interest. I would also like to briefly mention some upcoming events for the AACP. Our next complimentary webinar will be April 13th with Dr. Peter Vitruk on the myths and physics of soft tissue surgical dental lasers. We also have the medical CBD crash course for healthcare professionals with Dr. Gregory Smith on April 16th. And lastly, on May 20th through 21st in Fort Worth, Dallas, the AACP is hosting a 2-day dual course featuring fundamentals of TMJ and sleep for the new doctor and staff, as well as an Injection 1 traditional concepts course. Moderating for us tonight is John Nierman, the president of Nierman Practice Management. Nierman Practice Management is the leading organization for medical billing reimbursement in dentistry, providing the key education, systems, and support for dental practices. Their core solution dental writer software helps dentists streamline the workflow, documentation, and medical billing for TMD, dental sleep medicine, and oral surgeries. And I'll turn it over to John.
So thank you so much, Shaylin, and it's a pleasure to be with you all tonight and to introduce our speaker, Rose Nierman, who happens to be my mother and also one of the pioneers in medical billing for dental procedures. So Rose actually started out in this field as a dental hygienist in a busy TMD practice in the 80s, and it was her job to figure out how to get the medical reimbursement for their patients. And her dentist was actually one of the original members of the AACP, who then introduced Rose to the organization very, very early on. So Rose is actually also one of the very early members of the AACP. And since that time, she's been developing these protocols on how to implement medical billing and streamline those processes to make it easy. Since then, we've developed the dental writer software, as well as our education, our training, and our medical billing services to help streamline the entire process. But our philosophy and Rose's philosophy has always been the education, the systems, and the support. And it all starts with the education and the why. And that's what we're going to be talking about today, and specifically for dental sleep medicine. Rose has educated more dental professionals than any other person or organization, and stays up to date with medical billing protocols through our medical billing service. We're always finding out what's going on, what are the latest policies and codes, and we'll be sharing all of that with you today. So without further ado, I'd love to pass it over to Rose Nierman.
Hello there. All right. I think we're good to go here. Excellent. Well, thank you so much, John. That was a wonderful introduction. And I know, some of you I've known for a long time. We've got some new people here. John was born the same year as Nierman Practice Management. So I guess that's 30 something years. But we're very excited about sharing with you the new things that have happened in medical billing. Most of them positive, some not, but there's been quite a few changes in medical billing, as usual. Things do change quite quickly. As John had mentioned, we give the cross-coding seminars, dental writer software, medical billing service. We do a DME application for dentists who want to become a Medicare supplier, and give TMD and sleep education. The AACP, again, my dentist I worked with was one of the founding members. So I've been with this group for a wonderful time, or long time. So I'd like to put this at the beginning so you can sit back and relax and know that you can get in touch with us. You can contact us at contact@dentalwriter.com. Housekeeping item: practice is responsible for complying with your local and national guidelines, and this is not legal advice. So the agenda tonight, why medical billing for dental sleep medicine? Well, sometimes you just have to bill it as opposed to dental, but there's other reasons too. We're going to talk about the medical billing process, which services to bill, verifications, it's what you do up front the account, pre-authorizations. We're going to talk about the codes, and I was asked to talk about the new dental codes that came out. I'm not sure if you are aware of this, but new dental codes came out this year for dental sleep medicine. And then the importance of your documentation and your SOAP notes. So one of our sayings here at Nierman Practice Management is get your ducks in a row. And there's many ways you can get your ducks in a row for medical billing. What it comes down to is medical billing is all about having that right documentation of medical necessity. So that's what we're going to talk about today, how to get your ducks in a row. This is the Nierman team. Another one of our sayings is there's a code for that. We even have t-shirts that say there's a code for that, because there's a code for just about everything that you do in the dental office for which it can bill medical. Now, why would you want to bill medical? Well, it does set your practice apart. Patients are starting to expect it. So it does, differentiate your practice. It's going to increase the case acceptance. That's how I had gotten interested in this, is I would see that our patients had, the first office I was in was a TMD practice. The patients were in pain. It wasn't a dental condition. So we had this idea, let's build the medical. And that helps increase case acceptance. So many more patients can move forward with treatment, and also add additional revenue as you add these additional services to your practice. So it's going to help patients receive the treatment that they need, really life-changing procedures. I think also can save the dental benefits. Now, at the moment, dental doesn't pay for sleep apnea appliance. But for other things such as TMD, sometimes you're going to get that paid through medical as opposed to dental, or cone beam or surgeries. And dental benefits are limited, as you know, to $1,000 or $2,000 per year. Medical doesn't have that yearly limit. So when they do pay, it's going to be much higher. Dental limits the x-rays, how frequent the patient can have x-rays and exams, or at least get them reimbursed. Medical doesn't do that, because medical is going to pay based on medical necessity, not the frequency of the x-rays and exams. Now, there's very strong limits to dental insurance, and they just don't reimburse for some procedures. For instance, even though there's a new code, and we'll discuss that new dental code, I haven't seen a dental insurance company pay, maybe with an unspecified code, maybe twice in the years I've been doing this. TMD treatment, again, typically you want to build that to medical and leave the dental benefits, because if they have an appliance code, it's going to be probably a bruxism device. And in many cases, you're more likely to get that paid through medical. And sometimes you must submit to medical first. And a case that comes to mind is what insurance companies are doing now is they're telling dental practices, the dental insurance will say, we won't even process this claim for surgery until you bill medical first. And I think it's going to be with the new dental code for sleep, I think it's going to be the same. It's going to go through medical first. Now, different procedures in the DSM office. The private carriers or the commercial carriers typically will pay for a pan and an x-ray in addition to the sleep apnea appliance. And they'll also pay through the private carriers for follow-up visits after 90 days. So that's something to keep in mind. If you're billing Medicare, it's all going to be included in that. But different things, if you're doing frenectomies, to help the infants who have trouble feeding, any types of surgeries, accident cases. And we've seen some insurance companies step up and say, yes, we'll pay for Botox for the diagnosis of not TMD, but myofascial pain disorder, or painful bruxism, oral facial pain. So we have seen, them step up to paying for the Botox. Of course, you can always bill the Botox under migraines, but this is right down our alley with the myofascial pain. So it can work out really well. Now, another thing, it's very important. This is probably the biggest thing that you don't realize when you start billing medical. And it's the most time consuming part. It's what you do up front that counts. It's going to make the biggest difference in your success. And if you do the upfront benefits and gather your documentation ahead of time, it's going to make such a difference in your success. Now, so what do you do up front? Obviously, get the patient's insurance card, make sure you get copy both sides, and you can do a predetermination to see if they have the benefits, if the patient has benefits for the sleep apnea appliance. Now, once you do the benefit check, you're going to know about deductibles and co-payments, but you also want to find out, does this need to be pre-authorized? Sleep appliances typically do need to be pre-authorized. So you want to make sure you go through that process before you seat that appliance. Now, sometimes the patient wants to know a little more and maybe it doesn't need to be pre-op, but you can do a voluntary pre-op. When I call insurance carriers, if they tell me, oh gosh, we don't pay for this by a dentist, I'll tell them I have a diagnosis code. I have an ICD-10 code. So always be ready to give them the codes and they'll start reading the benefits to you. And then your documentation, your SOAP narrative report, and that's going to detail comorbidities and other treatments the patients had. Now, the pre-auth with the SOAP report and your documentation are usually done by fax with medical. So predetermination is calling and finding out if they have the benefits. A pre-authorization is, yes, these are the benefits. So that's the difference between a pre-D and a pre-auth. Now, there's a script. When you're called to verify medically necessary benefits, notice frequently I use the word medically necessary because they know by your tax ID it's a dental office. So right away at the get-go, I'm telling them, hey, this is a medical need. They'll provide your information and explain the symptoms. Excessive daytime sleepiness, patient has snoring, apneic events. It's urgent that this patient get treated right away. At that point, they'll ask either the CPT or the ICD-10 code, which is great because they can start looking at the policy then that's on their screen. And another thing that I ask in my script is, what documentation do you need? Okay, what exact documentation do you need to reimburse this? So being one step ahead of the insurance company is what's going to make the biggest difference. And that's why I say it's what you do up front that counts. If I gather all the documentation and send it to the insurance company at the get-go before they have a chance to deny it, then that's the best thing to do. The whole idea is to avoid denials. Get that paid as medically necessary the first time around. So when do you find out if a pre-op is needed? Again, always step one, the benefit check. Now, when you do the pre-D, it's a phone verification. And they'll start telling you the deductibles. They'll tell you if it's been met, how much of the deductible has been met. They'll tell you the co-payments, if there's any co-payment like 20%. Again, how important the pre-op. So that benefit info is available immediately, whether or not the patient has the general benefits and their co-payments too. Now, another thing that they might ask you, even when you do that benefit check, is what's the patient's AHI? Because there's a point that the insurance has as a cutoff where they're not going to reimburse, and that's an AHI of below 5. So I get calls all the time. Rose, do you think, patient has a 4.9, do you think we can sneak this through? No, that's their guideline. It starts with mild sleep apnea and AHI of 5. So that's important for the team to know. Also, you'll find out if the insurance is an HMO or a PPO and the other things that I mentioned. Sleep appliances are under durable medical equipment, just like a wheelchair or a CPAP would be. So one of the important things is to find out if they have coverage for DME. Okay, now when you give them the code I'm going to show you, they know that's a DME code, so you should be good to go. And lots of times they'll ask right on the phone, but they're going to need it in the SOAP report, are the comorbidities. We'll talk about those later. All right, now another thing that we like to find out during the verification or the pre-op is, even with commercial carriers, I want to find out if they're requiring a Medicare appliance, which is called PDAC or CMS for Center for Medicare Services, because some of the commercial carriers have gone with Medicare's list of approved appliances, which is like a Hertz type appliance or a connected appliance. Another thing is, once in a while, not every time, but United Healthcare started doing this, is they want you to give a referral from an MD in addition to the prescription. And so that's another thing you want to find out for each insurance company. And when our medical billers here at Nierman call, these are all the questions that they ask. Some carriers want the notes from the face-to-face appointment the patient had with the MD, whether it's a face-to-face or it could be a telemedicine appointment too. Those are accepted. And then they want to make sure that the patient doesn't have advanced or significant periodontal disease or TMJ disorder. So lots of things to keep in mind that come into play. All right, now codes. There's a code. See, that's one of our sayings. There's a code for them. When you start billing accident cases, you see there's a code for fall from ladder, fall on same level. Anything that happens to a person, there's a code. But let's get back to dental sleep medicine. And Courtney and I just gave our cross-coding course in Dallas this last weekend, and we did this pointing together because that's what insurance companies do. I believe they might try to do now that there's a dental and a medical code for sleep appliance. No, it's yours. No, it's yours. So the new dental code, there's a lot of confusion around it and what it's for. And some of the practices have been asking me, gee, Rose, who will we bill? All right. I don't have a crystal ball. But I was able to grab this from a magazine that we wrote in, and we haven't seen any payments yet for the dental code. But I did find, even just today, some medical policies and dental policies with the new codes in it. So that's interesting. All right, so the first new code is then these are dental codes. We'll get back to medical, I promise. The first one is the pre-visit patient screening. So that's for if you're billing the TMD exam, TMD or sleep, you can use the D9912 if it's covered. Okay, so that's a pretty new one. Just now, that would be for the longer exam. This would be for a quick sleep screening. Okay, so it's not going to be a long appointment at all. So that's the first new dental code that was added. Now, the ADA also added D9947, which is a custom sleep appliance fabrication and placement. Okay, so notice it doesn't say anything about follow-up visits. So that's your dental code for your sleep appliance. They also added D9948, which is adjustment of custom sleep appliances, and one for repair of a custom sleep appliance. Okay, so, now that there's a dental code out, what should we do? Well, I looked at this. We've been all year trying to find policies that have this code in it. And it was funny because finally today we found some policies. This is a Blue Cross Blue Shield policy that we find. They have listed those new codes in it. Here we are. And they say it's a non-covered benefit, just as I thought would happen. They're still going, like they do with surgeries, the dental is still going to defer to medical, to always billing medical first. So the codes, when the ADA came out with these codes, they said, oh, no, they're not really reimbursement codes, they're for documentation. So it's kind of interesting. But we did run across a policy that did state this. And then I found another one, this is Delta Dental, that said these are non-covered codes which are denied, but billable to the patient. Okay, so that's as far as we've gotten. I don't think too many practices have billed them yet because the practices are still going to be billing to medical. Okay, now I was also asked to talk about the new code for the sleep apnea appliances. All right, so I'm not sure if any of you are aware of this, but the K1027 came out in January. That's a durable medical equipment code, and it's oral device or appliance used to reduce upper airway collapsibility. Look at this, without fixed mechanical hinge. Custom fab includes fitting and adjustment. So that's interesting because we already have a code for a sleep appliance, which is E046, that doesn't mention anything about hinges. So this is going to be an interesting journey to see what happens with this. My recommendation is still bill, and I have the code coming up on my screen, still bill the regular code that we bill for medical, the E0486, okay? And then, as practices start billing this here and there, we'll start seeing what they're going to do with it. Interesting. But I did see on, I think this was Aetna's policy, again, today, they just updated it, that they do list that new code, K1027, but these are just kind of in general coding. Now, some of these codes I already know are not covered, like the E0486, that's a non-custom appliance, so that's not going to be covered. So this doesn't tell us if it's covered or not, but they are aware of it. Okay. Yeah, so that's it. This one, there's the Aetna policy, not covered. Okay, they went a little further on this policy and said it's not covered. Okay, so that's interesting. All right, so we'll give you the good code to use, the one that we'll be using when we're billing medical. And almost all medical plans, the good news is, do have coverage for oral appliances for the code of E0486, okay? As long as you have the right documentation. All right, so interesting information, a lot of changes. Another thing that changed this year, and these are really, really good changes, or this was changed, actually, it's been in place for years, but it's recent. Some of you may not be too aware, but they updated the guidelines for the evaluation management codes, which was very, very needed. So evaluation management codes, those are going to be your medical codes for your exams, and medical history taking. Now, they first came out by the AMA and Medicare in 1995. They revised them in 1997. And why do we need to know this? Well, because they weren't revised again until 2021. And what the situation is that you had to use a level 4 code, or even if you spend the 40 minutes or so, you had to show that you asked review of systems question and you examined certain body areas. And what they found is that physicians were spending all of their time documenting instead of treating patients. So I'm really happy that they changed those guidelines. They're good. And what they did is, on the new patient office visit codes, they removed the 99201, which is probably about under 15 minutes. So that's no longer, and that's okay, because I don't think you're not going to see just 15 minutes very often. Now, what they did is, prior to last year, time was a suggestion. Now they came out with time in total minutes for that. So this is very helpful. I would say before they changed the guidelines, we would tell practices, gee, even if you spend 60 minutes, you probably don't want to use a level 5 because that's a whole body exam. Okay, that's changed. That's really good news. So the established patient codes, you got the level 1, which is still available, and that can be staff time, 99211, up to a level 5, and they list the time. For instance, the highest level established patient code, 99215, is 40 to 54 minutes. Okay. So there's also, you may remember from the old coding guidelines, medical decision making, and that's the number of diagnoses, that how many management options you going to consider, complexity of records, diagnostic tests, and the risk of significant complications or morbidity or mortality. Now, what they did in the new guidelines is they say you can either go by time or medical decision making. Okay, so for a physician who's maybe managing, 6 or 7 conditions, that might make sense for that physician. But I think most of the dental practices will be going by time. Now, what's included in that time spent, those time increments that you saw, this is the total time on the date of the encounter. Okay, now the old guidelines, you had to be face-to-face with the patient and the provider the whole time. The new guidelines include both the face-to-face and non-face-to-face time spent by the provider. Okay, it also includes time and activities that require the physician or other qualified healthcare professional, but does not include activities normally performed by the clinical staff normally. Okay. Now, so what's included in the time spent preparing to see the patient, reviewing tests, obtaining or reviewing a separately obtained medical history, performing that medically necessary exam, counseling and educating the patient, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals, documenting, this is great, clinical information in the electronic or other health records. So the time can be even documenting in Dental Writer Plus and adding the questionnaire and exam findings. Independently interpreting results and communicating results to the patient, family, or caregiver, and care coordination. So you can see why I'm very pleased with these changes. Okay. Now you're still going to, let's say if you use a higher level code, a level 4 or 5, you're still going to want to show, that it was extensive, and that's where your SOAP report comes in. Okay, but it really has been great because they revised these to help providers spend more time on patient care. Back to the codes, sleep diagnosis code. The good news is there's only one OSA code, and that's whether it's adult or pediatric OSA. So this would be your ICD-10 diagnosis code, G4733. That's the one obviously that's going to come back on the sleep test. Includes fitting and adjustment. That's part of the coding wording. What does that mean? That means that the follow-up appointments, the calibrations are included for 90 days. So that you can start billing evaluation management codes after the 90 days. But typically, I'd say the vast majority of medical insurance companies and Medicare do include the 90 days. So that's important to know. That 90 days would be with the EO486. So that's your billing code. Back here, that's the diagnosis code. EO486 is going to be the code for the actual appliance, because with medical, you have both a diagnosis and a procedure code. Now, EO486 is oral appliance used to reduce upper airway collapsibility. And again, 90 days fitting and adjustment. Now, there's a couple modifiers, there's about 5 or 6 that you would use here and there that are important too for billing. So you've heard location with medical billing. It's especially for dental sleep medicine, it's documentation. That's what's going to get your claims paid. Okay. And the first thing they look at is if the patient comes in and just has snoring, that's not going to be covered. They've got to have a disease to the level of OSA. Okay. So as I mentioned, if the AHI is under 5, you can put in a snoring appliance or upper airway resistance syndrome appliance, but the insurance will not kick in then. Whereas if the AHI is 5 or higher, that's as long as you have the right documentation, that's when they're going to reimburse. The sleep study report, until maybe 3 or 4 years ago, it was kind of a gray area how old it had to be with Medicare, but they actually came out and said, okay, we want it to be within 1 year. Now, commercial carriers can vary. Sometimes it's a year. I've seen up to 3 years. Okay. The physician or the insurance will decide if it's a lab or a home sleep test, and that's where you'll get your OSA code. The sleep study must be signed by a board certified sleep physician, And you also need a prescription from a treating physician. That physician who writes the prescription can be a different provider than the one who was doing the diagnosing of OSA. Now, treatment options. As you know, the CPAP, according to insurance companies, is still, according to most insurance companies, that's going to change. It's still considered the gold standard. And oral appliances are an alternative to CPAP. And because of that, you have to show that the patient either refused CPAP, especially if it's severe sleep apnea, or maybe tried CPAP and is intolerant to it. So let's talk about documentation. That's the first line of defense, is to have that CPAP refusal or intolerance. Okay. Other things that they want is, obviously, I think everyone here is aware of what the Epworth Sleepiness Scale is. The magic number is over 10. So that's important, that if it's mild sleep apnea, they want to see that the patient has excessive daytime sleepiness. Other forms that are very, very common now to have to send in the proof of delivery form to the insurance company. So make sure that you have all patients, whether they're commercial or Medicare, sign proof of delivery that they received the appliance. And as you know, the SOAP report is the subjective portion, will be the complaints that they're having, the Epworth, the sleepiness, any comorbidities, as is the subjective part too, such as high blood pressure. And we do see sometimes the insurances want the clinical notes from the sleep apnea screening appointment with the physician. So that's why it's so important to find out in advance what the insurance needs. Now, if you look at the policies, what they say is if that patient has mild sleep apnea, documentation should include at least one of the following comorbidities: stroke, hypertension, ischemic heart disease, impaired cognition, mood disorders, or insomnia, or excessive daytime sleepiness. So right away, by sending this in, making sure that I screen for this and include my documentation, I'm already answering the questions that I know they're going to ask. Okay. So other clinical, sometimes you'll see that oxygen desat needs to be, say, less than 85%. So you see different things with different insurance companies. Okay. Other things too. Again, very important to know if that appliance, I know some of the Blue Cross Blue Shield and United Healthcare want that hinged PDAC appliance. They want to know that patient doesn't have active TMD, loose teeth. If it's severe, sometimes they'll say, I don't see it very often, that the patient must participate in a CPAP compliance program for like 45 days or something. That's used to be quite common, but it's much more rare to see that now. So those are the different things that you need to, make sure you gather so that we have it for the insurance. Okay. Medicare, you want appliance warranty. Once you become a durable medical equipment supplier through Medicare, then you want to make sure that you give the patient the one-page supplier standards or make them aware of it. Advanced beneficiary notice, ABN form for Medicare. That's something that we discuss at our cross-coding seminars, that it says if that's something that would normally be covered, but in this case, it's not going to be a service that would normally be covered, but it's not, might not be. That's where you have them sign the advanced beneficiary notice, telling them Medicare might not pay. Like if they've been on CPAP before, I recommend it. Okay. Another reason you want them to sign, it's a very standard form for Medicare. It's Medicare's form. Yeah, let's say you're not a DME supplier, but it would be paid, perhaps if the patient went to DME supply. That's when you have them sign an ABN. Different scenarios like that. You don't give every patient one. You don't do a blanket ABN, but for certain things, so you don't have to participate in refunds. It's smart. And then if the patient's been on CPAP before, you might want to in addition to having the patient sign that advance beneficiary that Medicare might not pay, make sure that you have a return receipt of the PAP machine for an appeal. So as you can see, documentation and your SOAP reports are your golden ticket to medical reimbursement, showing the subjective symptoms the patient has, all in the medical terminology. This is not your dental SOAP report. Your objective exam findings, the vital data, the airway exam, a little bit of a tooth exam, but more just to make sure the patient's a candidate for an oral appliance. Your assessment, always print your ICD-10 codes in your SOAP report for your assessment, because that's how they do a pre-auth in medical. They want that SOAP report with the codes in it, requesting that pre-auth. And the plan, of course, is any referrals that you're making and the treatment plan from this point on. So the SOAP's a perfect format to show medical necessity. Okay. Prescription. With Medicare, it's called the detailed written order. So that's the treating physician, who can sign that. According to Medicare, can be an MD, a DO, a nurse practitioner, clinical nurse specialist, or physician's assistant. Okay. The term physician in this case does not include a dentist. Some medical insurers like Blue Cross Blue Shield indicate the physician is an MD or DO who signs that written prescription. Okay. So that's important to have the elements to that. And you want, prescriptions come in all ways, shapes, and forms. Some practices make up with the proper elements in it so that you have something you can fax over to the physicians that you're working with. As far as the list of appliances, there's this is managed by the Palmetto GBE, a contractor for Medicare, and they list the codes that Medicare, not the codes, the appliances that many labs have gone ahead and applied to be an approved appliance in labs. So yeah, all the labs that we work with, that we see at our AACP meetings, they've all applied and have received, almost all of them, a Medicare product name, manufacturers and the product name. It's a lot longer than this, it's several pages. But yeah, you can get the list. I'd be happy to send you a link to this if you're wondering. Okay. Proof of delivery. All right, so documentation. This is interesting because this form has to have these elements in it. Unlike the prescription that might look a little different. This one, you want to have the patient's address on it. You, of course, want a narrative description. Can't hurt to have the code on it. This is important. Actually, the proof of delivery must enter the quantity. How many oral appliances did you deliver today? Okay. The date delivered and the beneficiary's signature. Okay. So you see why I say it's what you do up front that counts. Gathering this documentation. Once you realize what's wanted and needed, it takes the stress out of it and makes it much easier. And that's what this is about, making it easy. Here, there we go. We got a copy of the ABN. Again, this is to tell the patient that in this case, Medicare might not cover it. And so that's an official Medicare form. And it changed this year. So if you have ABNs at your office, let's go ahead and get the new one. We can either send it to you or you can download it from Medicare. Only one thing changed on it. I think it was one of the dates, but you need the new one. So gathering documentation, and that is gathering the medical history, the sleep history, using a treatment-specific questionnaire. So I'm sure all of you are using a dedicated sleep questionnaire and a dedicated exam where you can document your exam findings, whether it be the airway, you want to do a TMJ screening, make sure that it's all documented well. And that's from the questionnaire and exam, that's all your data is all going to come from to do that SOAP report. Okay. This is the Nierman Practice Management Sleep History Exam and Workup Questionnaire. Again, this form came about early on. We did TMD forms, sleep forms, oral surgery forms, and then the dentists that we've worked with over the years have been very sharing and helpful in updating them and adding things to them. So they're very good forms. All the symptoms that you see here, the chief complaints, there's a reason for all of these. So as we talked about, you've got to know if they refuse CPAP or they're intolerant, cognitive disorders, excessive daytime sleepiness, fatigue, impaired cognition, morning headaches, apneic events such as nighttime choking, and snoring, which affects the sleep of others. So there's a reason for everything, for your diagnosis, for your clinical use, and for reimbursement too. There's the Epworth. Again, I think there's one little line that's not on here, but this is the score that the insurance companies want to see is over 10. CPAP intolerant, they maybe refuse CPAP, or maybe they're having mask leaks, or they don't think it's effective, or maybe they're claustrophobic. So this is important to have your patients complete this section. Another thing that I've seen some policies that state, yeah, we'll cover an oral appliance if the patient tried not just CPAP, but maybe some other things. I've seen in some policies, well, they have to, try weight loss, or when I see a little more frequent would be the positional therapy. So again, rather than send a SOAP report without this information in it, and then they have to nickel and dime you with questions, we're getting this information to them at the get-go. History of treatment, that's who else, other providers that they have. The practices that we've worked with over the years have taken this list and they send the copy of the SOAP report to the other healthcare providers the patient has. So that's probably the biggest communication tool that you can do for practice building. But yeah, I think it's very respectful to communicate with the primary care, or of course the sleep physician, but maybe some of the other the practices that we've seen be very successful. You've sent them their cardiologist, and the SOAP report will start out, this is to keep you informed of our mutual patient. Sleep history, important information, more for your care. Sleepiness while driving, hopefully we discussed the risks if they put that. And then on the patient signature, we do ask the patient, or tell them by agreeing to this consent, you permit release of information, including examination findings, diagnosis and treatment program, to any referring or treating dentist or physician. So again, that's very helpful to send those SOAP reports out to physicians. The Nierman sleep history exam and workup exam form, I don't have every page on it, but obviously that's going to walk you through the airway exam, the tongue level above the occlusal plane, the Mallampati, the tonsil grades, uvula, soft palate, TMD screening, just all the things that you look for when you're doing a screening. So yeah, narratives to physicians and medical insurance for medically necessary procedure. I can't say that term enough. Medically necessary, to create that narrative, take that data from the questionnaire and exam and pull it together and send it with your medical claim too. Here's a sample narrative. This one is a sleep one. You've got all the elements, the Epworth, the CPAP intolerance, the other therapy attempts. I'm sure we have in here that, the TMJ, the joints are within normal limits, just like with PreOp, they want to know the TM joints are within normal limits. We printed your ICD-10 diagnosis code, so they know exactly what code you're asking for. And then I'll print the CPT codes too for the plan. So yeah, set up a repeatable system, use those dedicated forms, a dedicated questionnaire exam, send those reports to as many healthcare professionals as you can, and you're good to go to bill as well. All right, now this is just a portion of our Nierman practice management team. This is, the team that works very hard, as John said, education, systems, and support. And if you have any questions, we just have the best team there is, and we'll be happy to answer any questions, even after the webinar. I know we have a Q&A, but if your team have any questions, you can get with us. So, well, your ducks are in a row for medical billing.
Great. Well, we have a couple questions here, and I got the green light to go ahead and start firing off. Are you ready?
Yes.
All right. First question, are the billing systems applicable to Canadian providers?
No. From what I understand in Canada, that some of the practices were working are sending a letter of medical necessity. As far as I know, there aren't codes for it, but we do have some providers who are getting paid with that type of letter. Great question.
Awesome. Great. All right. Next question. What is the billing code for follow-up after the 90 days?
Okay, that would be the follow-up for after 90 days would be your established patient evaluation management code. For instance, if it's about 20 minutes, I would use the CPT code 99213. That'd be for a short follow-up. If it's longer, you could use the 99214, but probably more along the 99213, depending on how much time you spend.
Great. Have you seen more insurance denials on home sleep studies?
Really, in the last few years, the insurance companies are encouraging them. They don't always pay a dentist for it. So we have run into a couple who say, yes, we pay for home sleep study. Whereas our medical billing department does a lot of home sleep tests. So I haven't seen too much of an issue with them not reimbursing because it's a home test. They actually do encourage that.
Yeah, you just have to check your state guidelines.
Yes.
And
right.
So what if someone is interested in billing for a home sleep test and it is within their state, their dental board guidelines, what's that first step to know if there will be coverage?
Okay, that's a great question. I'm really glad you asked that. As I mentioned, the sleep appliance typically need to be pre-authorized. So do the home sleep tests. Okay, so it's the same format. You're going to pick up the code, and you're going to go ahead and pick up the phone, and you're going to go ahead and give them the code and find out if it's covered and ask what they need in the pre-auth, which you'll fax over. So it's the same thing. Now, sometimes with the home sleep test or even a cone beam that might need to be pre-auth, sometimes you can get an answer right on the phone for that. So it's not necessarily going to take 5 days to 2 weeks like it does with the appliance. Sometimes you can get an answer right away.
Okay, great. All right. What are the requirements when applying to be an approved lab, or where can the requirements be found? Does the lab have to be approved for coverage, or does it just help?
Let's start with Medicare. Yes, with Medicare, the lab has to be approved. And Medicare in their LCD, which is their local coverage determination, which is their guidelines, they state what type of sleep test it has to be. So they're very clear on that. A lot of things that Medicare has done, the commercial carriers, the private carriers have followed. So I would definitely, check with the insurance company and check the policies. For instance, you can do a web search for Aetna obstructive sleep apnea oral appliances, and all those, policies I'm telling you about that we look at, Courtney Snow and I look at, and keep up with. Typically, you can find the general policy for the main insurance companies because they do need to be transparent about what is required. So yeah, it might be, have to be a certain type, but you can know that in advance.
All right, last question. What is the letter we use to send our patient's physician once they have completed the efficacy testing?
What you want to do is, and Dental Writer Plus has a follow-up visit. So the different visits where, whether you're doing it by hand with the forms or use a system, the first appointments, you're screening and or history exam and workup. Sometimes you'll do two, a screening and an exam. Then you do the appliance delivery. The follow-up appointment is the one that the first one typically the doctor will get. And what most of the practices we work with, they like to have a trend report comparing the AHI with the previous AHI and the LPOR score with the previous one too.
Perfect. All right. Final last question. Hi, thanks for the info so far. How old can the sleep study typically be? I know it will benefit a patient to have every 3 to 5 years to check on their condition, but
Yeah.
if the physician won't recommend a new one. But first question, how old can the sleep study typically be?
It used to be a gray area with Medicare, but they finally came out and said it must be a year. Now it's different with commercial carriers. We see 3 not being uncommon with commercial carriers, but it behooves you to check because it could be one that goes with Medicare. But usually on private carriers, it's 1 to 3 years.
Well, that is all the questions. So I will pass it back to Shaylin, and thank you guys so much.
Awesome. Thank you so much, Rose, for all the great information. Very informative. Thank you both for your time this evening. And thanks to everyone who is in attendance of the webinar. Have a great evening.
All right. Let me know if I can answer any questions. Thank you so much. Everyone have a great evening.
Thank
All
you
right.
so
Thanks,
much.
everybody.
Bye.
Bye-bye.
Bye now.